Planning for a totally edentulous situation. Patient is very old, female, long-term denture wearer, highly thinned out ridge, very knife edge ridge. We'll see how we can rehabilitate with implants. So sinus expansion is more on both sides, anteriorly, especially more on the left side. There is no nasomaxillary buttress here. Nasomaxillary buttress is invaded by the sinus. Nasomaxillary buttress is thinned out because of the sinus expansion. But atypically there is some bone in the 6-7 area. In left side there is no bone in 6-7 area, but right side there is bone in 6-7 area. The sinus expansion has not occurred downwards on the right side, but it occurred mesially on both sides. We are planning for pterygoid, so we will see the pterygoid now. If you see the panoramic view, the pterygoid looks it is been down than the anterior. It may be an artifact, it may be illusion, or it may be real. Maybe we will see the 3D reformed view. We will cut out the unnecessary part. If you see here, the right side, the pterygoid is little bit downward. Whether it is resorption on the premolar molar side, or it is a sinus expansion, tuberosity downward expansion, we don't know. Okay, here also we can see the tuberosity is coming down. Whether the tuberosity is coming down or the bone loss in premolar, crestal bone loss in premolar molar region, we don't know. So what is the significance of this tuberosity downward expansion is the abutment may hit on the lower tissue, mandible. So this we have to confirm before. Make the patient in the centric relation and gently open the lips and check the tuberosity area. Observe the space between the tuberosity and the lower mandible. If there is enough space, there is not an issue. Otherwise, we have to do some alveoplasty. Okay. So this is the trickiest part, because in combination syndrome, the tuberosity may come down because of long-term denture wear and anterior chewing pattern. So we will plan for the pterygoid right side. So it is a PARP 1 type. The sinus expansion is very much favorable. It is very much. So we can start 12 mm in front of the hamular notch. The more sinus expansion is there, we have to start more closer to the hamular notch. Comparatively, the bone quality is very, very poor. Only the tuberosity, only the crestal bone is very thin cortical bone. Otherwise, the entire tuberosity is cancellous bone. Even the pterygoid junction is not looking great. So we will see the buccolingual cross section. So the tuberosity bone is there, but it is like without bone. It is like a hollow. The bone inside the tuberosity is not of any use. Okay, so only the pterygoid junction area we may get some good bone. But if you are planning for some implant having lesser length, for example, if you plan for a neodent having only 18 mm, if you put only 18 mm, you will be within the less compromised bone, compromised bone. The more apical you go, the more better bone you will get. So you may need longer implant in this situation. Check whether neodent long is there. If it is there, you can place 24 mm or 22 mm, something like that. Otherwise, you can change a brand having longer implant, say 22 or 20 or 22. Okay. So, we have to do the medial tilting, correct medial tilting. If we go laterally, the bone quality will be much more poorer. Okay, but if you tilt more distally, then the length will be very less. It is around 20. It is around 20. Okay, so even then you need a 20 mm implant. Okay, 18 won't be sufficient. Otherwise, what you can do is, in this kind of, if length is the issue in selecting the implant, you can do alveoloplasty. For 3 mm, 4 mm alveoloplasty, if you do, you can place a 18 mm implant and you will get a good stability. So that is one option. Left side, we'll see. Left side is a little challenging because of sinus expansion, but not very challenging. Exactly in this area between the sinus wall, maxillary sinus wall, and this hamlar notch, this is the spot. Here we have to go. If you go in this direction, it will go into the sinus. If you go here, it will be a poor quality bone and fully into the tuberosity. So here we have to go. Okay, so how to achieve this? By taking IOP after the pilot drill. And if you see here, the bone is more on the medial aspect, the junction. So tilt medially, and length is also good. It's more than 18. Because the tuberosity length itself is very high, we have to use a longer implant to catch the pterygoid junction in this situation. So it goes even 23. So very rarely you may get this length. But if you tilt little bit distally, there is no option for tilting here because this area between the sinus wall and the pterygoid amular notch is very less. So you don't have much option in distal tilting. So you need a good length implant to get stability because the bone quality is poor. Even the pterygoid junction is very poor, very cancerous. Very osteoporotic. The pterygoid also is osteoporotic for this patient. So now we will come for the right tilted. Because of the sinus expansion involving the nasomaxillary buttress, our target point is the NC point, which is the nasal corner point, this corner, the junction of lateral nasal wall and the floor. The deepest point is the nasal corner. The nasal corner is the option for us. So here also we should not, the complication is we may go into the sinus or we may come very close to the sinus. So how to avoid this complication? Take IOP after pilot drill. The challenge is to thin ridge and extremely osteoporotic bone, and nasal floor is also not great. So we have to do palatal approach. So only this cortical bone and some amount of nasal floor and inside poor quality osteoporotic bone, they will give some support. So we have to do very much under drilling, and we have to use a compressive type of implant, not active threads. So you can use the neodent or brilliant is very ideal for this situation. Okay, so neodent also you can use 3.75 or 3.5. So the length is around 16 mm. Based on the alveoloplasty you have to do. Anyhow, we will be checking the prosthetic space after opening the flap or before opening the flap. On the left side, the nasal floor is quite okay, but not okay fully. This palatal bone also is good. So when doing the palatal approach, this palatal crestal bone and the nasal cortical thin bone, which will give stability. That's it. So use 3.5. Using wider implant for palatal approach, it may bring the abutment more palatally. So use pilot drill and use only the 2 mm or even 1.8 mm twisted drill is enough. Not use more than that. We need to perforate the nasal floor, then only the implant will go. Otherwise the implant may spin. That is also one thing is there. And anterior axial implant is also challenging. Thin ridge. You have to do very slowly. Select the correct implant length. We should not shoot too much into the nose. If at all, if achieving stability is a problem in axial implant, what you can do is you can tilt medially so that you can try to engage the more better midline bone. Okay, that is a plan B for anterior axial if something happens in stability. Otherwise, there is one more option. Plan C is don't put any axial, 2 axial, place only one nasopalatal canal implant. The nasopalatal canal is definitely you will get good stability. Don't worry about the canal, just sever the canal and drill for your ideal bone level position and prosthetic position. Okay, so bone level we should know it should be covered by bone labially, and prosthetically we will know what is the approximate ideal position. Based on that you can drill. You don't have to worry about, don't think about canal. Okay. Actually the canal is very much backwards, so it is not at all coming in your pathway. So you will be placing implant entirely anterior to the canal. This is a rare situation. Usually the canal will come in the way of the implant, but here the canal is here. So if you place the implant, it will be fully away from the canal. So palatal approach, the key thing is you have to reflect the palatal flap adequately. Otherwise if we don't elevate the flap here, then we may start the drilling too close to the crest and it becomes a crestal approach. So only when we reflect adequately, we may have to start the drilling from here, not from here, from here. Okay, so in the slope we have to start the drilling, not from the crest, in the slope. But how much distance from the crest palatally we have to start, that is the question. Maybe for this patient 3 mm from the crest towards the palatal direction. And when you finish placing the implant, the crestal part of the implant should be abutting the bone here. That is the key part. There should not be any gap between the implant and the palatal bone. If there is a gap, then it will become a failure. Okay, that mistake will happen if you drill too much into the palatal slope, too much deep into the palatal slope, and if you drill, then you will have a gap. So that thing we have to manage. Okay. So extraction wise there is no challenge here. The only challenge is in the implant placement part. So pterygoid is the key implant. So while placing the implant, focus on pterygoid implant and finish that, and then come to the anterior part. And coming to the molar area, this area we can keep it as a backup option. If pterygoid is not possible, we can use this area for implant, or we can put a sleeping implant also. We can put a sleeping implant also here.